Welcome to the deep dive. Today, we are really immersing ourselves in one of the most stressful, time-critical, and frankly complex medical decisions facing surgeons and neurologists right now. This isn't just about looking at numbers. It's about this incredibly tight life or death timeline where two vital treatments for acute stroke seem to collide head on.
It really is a high wire act. We're
Ugh.
focusing on today is the outcome when a patient has had an acute ischemic stroke. They've received the standard, often life-saving clot-busting drug, that's intravenous thrombolysis, IVT, and then very soon after, they also need surgery to fix the likely cause of that stroke, which is often a severely blocked carotid artery. And that surgery is carotid endarterectomy, or CEA.
Right, the CEA. So the central conflict, and this is what our source material really digs into, is figuring out the safest way forward. Does giving that IVT first, this powerful chemical designed specifically to dissolve clots, does it create such a huge extra risk of bleeding or even stroke or death during the later CEA surgery that we absolutely have to wait? And if we do have to wait, how on earth do we pinpoint that exact moment when the benefit of doing the surgery finally outweighs the lingering risks from the drug?
That's the core question. And our deep dive today pulls its insights from a really crucial systematic review and meta-analysis. This work specifically set out to compare the results, the outcomes, for patients who got IVT and then had CEA versus patients who just had the CEA without getting recent IVT. We're looking for those measurable differences in safety, primarily.
Okay, before we even get into the data itself, let's just pause and fully appreciate the stakes here. Why is this topic so urgent? Stroke is just a massive global issue, right? Remind us of the scale.
Oh, the scale is immense. And honestly, I think it's often underestimated by the general public. Stroke is still the second leading cause of death across Europe. It's the fourth leading cause in the United States. And maybe even more sobering, for those who survive a stroke, the long-term picture isn't always great. Over half, more than 50%, are left with some kind of significant, often permanent disability. So when a patient hits the emergency room door in the middle of an acute stroke, the clock isn't just ticking, it's screaming.
That urgency, that screaming clock, leads directly to the first big intervention, IVT. For listeners who maybe aren't dealing with stroke protocols day in and day out, what makes IVT such a cornerstone, that first step, and what's the inherent downside?
Yeah, IVT, usually given as a drug like alteplase or TPA, it's really considered the absolute mainstay treatment for acute ischemic stroke, the kind caused by a clot. It works exactly as you said, by chemically dissolving the clot that's blocking blood flow in the brain vessel. But its effectiveness is completely tied to timing. It has to be given within a really tight window, traditionally up to 4.5 hours from when the symptoms first started.
And when it works within that window, it can be almost miraculous, right?
Absolutely. It manages to open up that blocked vessel, achieve recanalization in, over 50% of patients who receive it. And studies suggest about a third of those treated patients get a really significant clinical benefit, meaning less disability. However, the very thing that makes it so effective, its power to dissolve clots, is also its biggest safety concern.
The bleeding risk.
Exactly. IVT comes with a known, and it's not insignificant, risk of causing bleeding inside the brain. That's called intracranial hemorrhage, or ICH. Looking across large patient groups, this complication happens in roughly 6% of patients who get the drug. It's always a calculated risk. You accept that 6% risk of a potentially major bleed to try and save brain tissue, but that risk doesn't just vanish the moment the infusion stops.
Okay, so that's step one, life-saving potential, but introduces this bleeding risk. Now, step two, the surgery. Why does a vascular surgeon often need to get involved so quickly after the initial stroke treatment?
Because just treating the current stroke, dissolving that one clot, often isn't enough. We have to think about preventing the next one, which could be even worse, potentially fatal. We know the extracranial carotid stenosis, that's a significant narrowing or blockage in the main artery in the neck supplying the brain, is the underlying cause in about 20% of all ischemic strokes. That blocked artery, with its unstable plaque, is like a ticking time bomb. It's an ongoing source of what we call thromboembolic debris, little bits of clot or plaque that can break off, travel up to the brain, and cause stroke after stroke.
So the CEA, the surgery, is about removing that source, stabilizing things for the long term.
Correct. For patients who are symptomatic, meaning they've already had a warning sign, like a TIA or an actual stroke, and they have significant stenosis, usually defined as 50% to 99% blocked. Well, for them, CEA is strongly recommended. The operation literally cleans out the plaque from the artery, stabilizes the vessel wall, and dramatically cuts down the risk of future strokes from that source. And crucially, the guidelines push for urgency here too.
So the urgency of the surgery runs right into the bleeding risk from the drug, given just hours or days before. What kind of timeline did the guidelines suggest for the CEA itself?
Well, the guidelines generally recommend that CEA should be done, ideally, within 14 days of the initial stroke, or TIA. The thinking there is you want to intervene before the patient has another event. When that artery is badly blocked and unstable, the risk of another stroke happening soon is very real. Plus, operating early might help salvage the ischemic penumbra, that area of brain tissue around the core damage that's stunned, but potentially recoverable if blood flow is restored quickly.
So this is the tightrope we mentioned. IVT within maybe 4.5 hours to save the brain now, but that introduces this lingering bleeding risk. Then, the push for CE within 14 days, often much, much sooner, to prevent the next stroke. This creates what the study calls the IVT-CEA clinical situation. And the big question is operating really early, say, on day 2 or day 3 after IVT, just too dangerous because of the leftover effects of that clotbuster?
That is precisely the question this deep dive aims to answer using the source material. It's all about the safety profile when you combine these two very necessary but potentially conflicting high-stakes treatments. It really boils down to, how do we balance the urgency of IVT with the urgency of CEA while making sure we don't cause a different kind of disaster in the process?
Okay, let's really get into the study then, because the methodology had to be incredibly careful to try and answer such a critical question about timing and risk. You said it was a systematic review and meta-analysis comparing IVT-CEA versus just CEA alone. How did they go about finding the right studies?
They started with a really comprehensive search, hitting the major medical databases, Medline, Embase, Cochrane. They used specific search terms designed to find all the relevant comparative studies. The key was finding studies that clearly reported outcomes for both groups. The group that got IVT, then CEA, and a control group that just got CEA without recent IVT. Rigorous comparison was the goal.
And you mentioned it's tricky in modern stroke care because there are other treatments now, like physically pulling the clot out. They had to filter those out, right, to isolate the risk just from the chemical clot buster.
Exactly right. They were super focused on isolating the risk from the chemical agent, the TPA. So they specifically excluded studies that involved mechanical thrombectomy, where they use a catheter to physically retrieve the clot. While thrombectomy is often used, sometimes with IVT, it has its own set of procedural risks that would muddy the waters here. They also kicked out studies looking at intraoperative thrombolysis, giving the drug during the surgery, and studies focused on carotid artery stenting, or CAS, because stenting is a whole different procedure with a different risk profile compared to the open surgery, CEA. And one more thing. They only included studies that were comparative and had at least 10 patients in each group, just to ensure there was some basic level of statistical stability in the comparisons.
That sounds like a pretty strict filtering process. After applying all those rules, what kind of data did they end up with? How many studies and patients made the final cut for this meta-analysis?
Well, the final data set they pulled together was pretty impressive just in terms of size. That definitely gives the conclusions some weight. They synthesized data from 11 different retrospective comparative studies. And pulling all those together, they had a massive total of 326,682 patients included in the analysis.
Wow, over 325,000 patients. That's a huge number. But you hinted earlier that the way those patients were split between the groups is absolutely critical for understanding the results, especially the initial findings.
It really is the defining feature you have to keep in mind. So out of that huge total, the vast majority, 135,644 patients, were in the standard CEA alone group, the control group. The specific group we're most interested in, the ones who got IVT first and then CEA, well, that group contained 2,070 patients across all the studies. So you see the dynamic. We're using this enormous broad comparison group to try and understand the outcomes in a much smaller and arguably much higher risk specific subset of patients.
Yeah, that difference is vital. A huge control group likely including many lower risk patients compared against a smaller group who were all sick enough to need IVT for an acute stroke.
Yeah.
Okay, let's define the outcomes. What were they actually measuring within that first month after surgery?
They focused on safety and immediate results, tracking 5 key outcomes, all measured within 30 days of the CEA operation itself. First, any perioperative stroke happening around the time of surgery. Second, death from any cause. Third, they combined those into a composite outcome, stroke or death. And then crucially, the 2 big hemorrhagic outcomes we've been talking about, intracerebral hemorrhage, ICH, that's bleeding inside the brain, and the surgical site bleeding, specifically any neck hematoma bad enough to require another operation.
Okay, outcomes defined. Now, before we even look at the results, you flagged something really important about the methodology, this issue of high statistical heterogeneity. The researchers reported something called I-squared values, hitting 92%, even 93% for some of the initial pooled results. Can you explain for us in practical terms why an I-squared value that high is like a huge flashing red light?
Yeah, high statistical heterogeneity, especially up in the 90s, is basically the statistics telling you, hold on, the FETs you're trying to combine here are really, really different from each other. An I-squared value over 75% is already considered high heterogeneity. When you get to 92 or 93%, it means the results across those 11 individual studies were wildly inconsistent. They weren't all measuring the same underlying clinical effect. It's like averaging apples and oranges, maybe even apples and chainsaws. The average doesn't mean much.
But why would they be so different? They were all looking at IVT followed by CEA, right? What causes that much variation?
It likely comes down to huge differences in who was included in the studies and how they were treated at different hospitals. For example, maybe one study came from a big academic center in the US with a top-notch neuro ICU, and they were doing CEA super early, like 6 hours after IVT, but only on patients with really severe strokes. Then maybe another study was from a smaller hospital, maybe in Europe, operating on day 7, and they included patients who had milder strokes but still got IVT. Plus, you have variations in how they selected patients, the exact timing protocols, how tightly they controlled blood pressure, how they managed antiplatelet drugs.
Yeah.
All these things mean that just lumping all the results together gives you a number, but it might be quite misleading.
So if the results are all over the place, how do researchers even proceed? You mentioned they use something called a random effects model because of this heterogeneity.
That's the standard statistical approach when you have high heterogeneity. Instead of assuming there's one single true effect size out there, that all the studies are just estimating imperfectly, that's the fixed effects model. The random effects model is more realistic. It acknowledges that the true effect probably does vary from study to study because of all those differences in patients and protocols we just talked about. So it still combines the data, but it does so more cautiously. It gives wider confidence intervals and basically forces us to accept that the pooled number is just an average of a diverse set of situations. It pushes us to dig deeper and ask why the results vary, not just what the average is.
Okay, that makes sense. A necessary dose of caution before we look at the numbers. So let's dive into those numbers now, keeping that high heterogeneity and the need for caution firmly in mind. When you first look at the raw pooled data for stroke and death, it looks pretty damning for doing CEA soon after IVT.
It certainly seems that way on the surface, yes. If we just look at perioperative stroke by itself, the overall pooled rate in the group that got IVT, then CEA, was 4.2%. Now you compare that to the big CEA-only control group, where the pooled rate was only 1.3%.
Okay, 4.2 versus 1.3. That's more than a threefold increase in the risk of having a stroke during or right after the surgery if you got IVT beforehand. That sounds bad. And what about when you combine stroke and death together?
The combined stroke death rate showed a similar pattern, maybe even starker. It was 5.9% in the IVT-CEA group compared to just 1.9% in that large CEA-only group.
5.9% versus 1.9%. Again, looks really concerning. The simple interpretation might be, wow, IVT makes CEA way too risky. Maybe we shouldn't do it early or at all. But as we discussed with the methodology, we absolutely have to question why that control group, the CEA-only group, had such an incredibly low baseline risk of only 1.9%.
Exactly. This brings us right back to that crucial confounding factor, the clinical makeup of the control group. Why was the risk apparently so low in those 135,000 plus CEA-only patients? Well, it's because in these kinds of retrospective studies, that control group inevitably includes a lot of patients who came in with much lower risk problems. Specifically, many patients in the CEA-only arms likely presented with a transient ischemic attack, TIA, where the stroke symptoms disappear completely and quickly, or maybe amaurosis fugax, which is temporary blindness in one eye from a blockage. Now, these events definitely signal unstable plaque in the carotid, and they absolutely need CEA to prevent a major stroke. But crucially, the brain tissue itself is largely, or maybe even entirely, unharmed in those cases.
So it wasn't a fair comparison initially. We were comparing a group of patients who, by definition, had suffered a significant, often quite severe stroke needing aggressive IVT treatment against a much larger group, many of whom had just experienced a warning shot, like a TIA, with no permanent brain damage. That's apples and oranges for sure.
It really is. And the sources emphasize this point. Patients who have suffered a full ischemic stroke are just inherently at a higher risk of having another stroke during or after CEA, regardless of whether they got IVT or not. Why? Because their brain has already taken a hit. The blood-brain barrier might be leaky, the brain's ability to regulate its own blood flow might be messed up, and there's often that vulnerable penumbra of tissue that's super sensitive to any changes in blood pressure or flow during surgery, like when the surgeon has to clamp the artery.
So the IVT isn't necessarily the direct cause of that higher stroke risk seen in the initial comparison. It's more like a marker indicating that the patient was much sicker neurologically to begin with.
That's a great way to put it. The need for IVT flags a higher baseline neurological severity. So to really isolate the added risk from the IVT drug itself, the researchers did that crucial next step, the sensitivity analysis.
Right, the sensitivity analysis. Tell us what they did and what happened when they tried to make it a more apples-to-apples comparison.
Okay, so what they did was systematically exclude the studies where the control group, the CEA-only group, included patients who only had a TIA or amaurosis fugax. They refined the comparison so they were looking at the IVT-CEA patients versus a CEA-only group that only included patients who had also suffered a definite stroke. Now we're comparing stroke patients to stroke patients. And this is where the results really shifted the narrative from that initial alarming finding.
Okay, embraced. What did the risk numbers look like in this stroke versus stroke comparison?
All right, the risk of the combined outcomes, stroke or death, in the IVT-CEA group actually came down a bit from 5.9% to 3.6% in this analysis. But here's the key part. The risk in the comparable CEA-only group, the ones who had a stroke but didn't get IVT, that risk rose significantly. It went from that artificially low 1.9% up to 3.0%.
Wow. Okay, let that sink in. 3.6% risk for IVT-CEA versus 3.0% risk for CEA after stroke without IVT.
That difference is tiny, only 0.6 percentage points higher, potentially attributable to the IVT itself. Exactly. And statistically, that small difference was no longer significant. The p-value was 0.11. This, you could argue, is one of the most important and frankly reassuring findings from the entire analysis. It strongly suggests that when you compare like stroke patients with stroke, patients giving IVT beforehand does not seem to dramatically increase the risk of having another stroke or dying from the surgery compared to operating on a stroke patient in general. So maybe clinicians don't need to be quite so terrified that the TPA itself is going to cause a new clot or a new ischemic event during the CEA. They can focus more on the standard surgical risks for a stroke patient.
That's really significant. So the fear about IVT causing more ischemic problems during CEA seems largely unfounded when you compare properly. That's the good news. But let's go back to that initial pooled risk for the IVT-CEA group, the 5.9% for stroke death. You mentioned earlier that the major guidelines say the combined risk of stroke and death for symptomatic CEA patients should be less than 6%.
Yes, and that pooled rate of 5.9% does technically squeak in just under that 6% threshold. This is also important. It suggests that overall, performing CEA in this very high-risk population can still be managed within acceptable safety limits, on average. However, and this is a huge however, that 5.9% average hides a critical truth. The risk isn't spread out evenly over the 30 days. It's heavily front-loaded in the first few days. And this realization shifts our focus away from the ischemic risk, which seems manageable, and squarely onto the hemorrhagic risk, which turns out to be the real driver of early danger.
Okay, but just to push back slightly, if the overall average is 5.9%, which is within the 6% guideline, and the sensitivity analysis showed the ischemic risk isn't much higher, why should a surgeon still hesitate to operate quickly, say on day 2, if they feel confident they can manage the surgical technique?
That's a fair challenge. It's because that 5.9% average is calculated from studies where the median time to surgery varied hugely, sometimes up to 11 days. Some patients waited a long time, pulling the average down. As we'll see when we look at timing, intervening very early pushes the predicted risk well above that 6% threshold. The 5.9% average is only achieved by balancing very high early risks with lower later risks. And the component that skyrockets the risk in those first few days isn't the recurrent stroke. The sensitivity analysis helped ease that concern. It's the catastrophic bleeding. And that's what we absolutely need to dissect now.
Okay, that's the perfect pivot then. The main safety issue isn't about the artery reblocking and causing another stroke during surgery. It's about the surgery itself causing bleeding, because the IVT has made the patient vulnerable. Let's really focus now on the numbers for that hemorrhagic risk.
This is where the data becomes quite stark. Let's look first at intracerebral hemorrhage, ICH, bleeding right into the brain tissue. This is the complication most directly associated with IVT.
What did the comparison show for ICH rates?
Okay, get ready for this. Patients in the IVT-CEA group had a proved risk of ICH of 2.5%. Now compare that to the CEA-only group. Their risk of ICH was practically negligible, just 0.1%. The difference was massively statistically significant, p.001.
Whoa. 2.5% versus 0.1%. That's a 25-fold increase in the risk of bleeding inside the brain if you had IVT before your CEA. That single statistic really explains all the caution, doesn't it? It explains why surgeons are so hesitant to operate early. A post-operative ICH is often devastating.
The clinical significance here is huge. An ICH isn't like a small stroke you might recover from. It can expand rapidly, cause massive neurological deficits, brain herniation, even death. It can turn a technically successful surgery into an absolute neurological disaster. That's why this 2.5% figure, even though it sounds like a small number in isolation, carries immense weight and frankly overshadows the ischemic stroke risk we just discussed when thinking about early surgery.
But I'm still stuck on the timing. The drug itself, the TPA, has a really short half-life, right? Like 4 to 7 minutes. So by the time the patient gets to the operating room, maybe 2 or 3 days later, shouldn't the drug be long gone from their system? Why does this vulnerability to bleeding persist for so long?
That's a critical question, and the sources point to two main reasons why the risk doesn't just disappear when the drug is metabolized. First, the bleeding that IVT triggers, the hemorrhagic transformation of the stroke area, doesn't always happen right away. The sources remind us that up to 20%, 1/5, of IVT-related brain bleeds actually occur after the first 24 hours following the drug infusion.
Wait, 20% are delayed beyond 24 hours. That implies the standard practice of just watching a patient closely for the first day after IVT isn't enough to say they're safe for surgery on day 2?
Exactly. The damage process initiated by the drug can take time to fully manifest as visible bleeding. The clot lysis triggers inflammation. It causes reperfusion injury when blood flow returns to damaged tissue. These processes unfold over hours and days. So, if a surgeon rushes a patient to the OR on the morning of day 2, they might actually be operating right in the middle of that peak window for delayed hemorrhagic transformation.
Okay, that's one mechanism, delayed bleeding. What's the second reason the risk lingers? You mentioned something more subtle.
Yes, it's about the longer-term damage to the tiny blood vessels in the brain and the blood-brain barrier, the BBB. IVT is known to be associated with the formation of what are called cerebral microbleeds. These are tiny, often microscopic spots of bleeding that show up on sensitive MRI scans in about 15 to 27% of patients after IVT. They often don't cause any immediate symptoms themselves, but they are like little warning signs. They indicate that the walls of those small vessels have been weakened and the BBB integrity is compromised.
So the BBB, the protective layer that normally shields the brain from big swings in blood pressure and chemicals in the blood, has been chemically damaged by the IVT?
That's the idea. It's become leaky, less robust. And now, think about what happens during CEA surgery. It's a significant physiological stress. The surgeon has to clamp the main carotid artery for a time. To keep the brain perfused during clamping, they often need to maintain a relatively high systemic blood pressure. Then, when the clamp comes off, you get this sudden rush of blood flow back into the vessels on that side of the brain, often at that higher pressure.
And that surgical stress, the clamping, the pressure changes, the sudden reperfusion hits those weakened vessels, the ones flagged by the microbleeds.
Precisely. If those microbleeds tell us the vessel walls are fragile and the BBB is leaky, then the physiological stress of CEA acts like the trigger. It can turn those tiny, silent microbleeds into a major catastrophic bleed, contributing to that 2.5% ICH risk. You could think of the TPA as lighting a chemical fuse on the brain's vasculature, and operating too early is like applying the spark.
And the bleeding wasn't just limited to the brain, was it? The sources also found a higher risk of bleeding right there at the surgical site in the neck.
That's correct. It seems the systemic effects of IVT on the body's overall clotting ability linger as well. The IVT-CEA patients had a significantly higher risk of developing a neck hematoma around the surgical wound that was serious enough to require re-intervention, meaning going back to the operating room. That rate was 3.6% in the IVT-CEA group, compared to 2.3% in the CEA-only group. Still statistically significant.
Okay, maybe a neck hematoma isn't usually as devastating as a brain bleed, but a 3.6% chance of needing emergency surgery on the neck wound is still a major complication. It adds risk, hospital time, cost. And it really reinforces the idea that the body's whole clotting system is still somewhat out of balance for days after getting IVT.
It absolutely does.
Yeah.
And a neck hematoma can be life-threatening. If it expands very quickly and compresses the airway, it might require an emergency reopening of the incision right at the bedside, which is not ideal. So the take-home message from this section is crystal clear. The overwhelming reason to delay CEA after IVT is the significantly increased risk of bleeding, both in the brain and at the surgical site. It's not primarily about the risk of another clot or ischemic stroke during surgery.
Okay, so if bleeding is the big enemy here, the whole game shifts to figuring out the optimal timing. How long do we need to wait for that bleeding risk to cool down? We know we want to operate within 14 days ideally, but we've just seen that operating on day 2 looks really dangerous because of bleeding. So how did the studies try to find that sweet spot?
Well, this is where the analysis really provides value, because the first thing it establishes is that current practice is kind of all over the map. It's highly non-standardized. When they looked across those 11 retrospective studies they included, the variation in when they did the CEA after IVT was enormous.
Give us a feel for that variation. How wide was the range?
The median time between giving the IVT and doing the CEA surgery ranged from as little as just 2 days in some studies all the way up to 11 days in others. So centers were clearly making very different calls, presumably based on local protocols or surgeon gut feeling about when it felt safe to operate. And we saw some really aggressive examples in the mix. One study reported that nearly half, 46% of their IVT-CEA patients had the surgery within just 24 hours of getting the clot buster. Another reported over 50% were operated on within 72 hours, or 3 days.
Operating within 24 hours.
No.
Knowing that 25-fold higher risk of brain bleed, that sounds incredibly risky based on the data we've just discussed. It really underscores the need for some evidence-based guidance on timing.
The desire to get that unstable plaque out immediately is understandable from a surgeon's perspective. But yes, the meta-analysis provided the tool to really quantify that risk. The researchers performed what's called a meta-regression analysis. Essentially, they tried to plot the mathematical relationship between the length of the time delay in days after IVT and the resulting risk of that combined stroke-death outcome.
So they were looking for a pattern. Like, does the risk drop consistently the longer you wait? What did that meta-regression show?
It did confirm that general idea. They found an inverse relationship, meaning as the time interval between IVT and CEA got longer, the risk of stroke or death did trend downwards. Interestingly, though, while the downward trend was visible in the data, the relationship itself didn't quite reach statistical significance in their overall model. The p-value was 0.268.
Huh. Why wouldn't it be statistically significant if the trend was there? Does that weaken the argument for waiting?
Not really, no. Remember that extreme heterogeneity we talked about, the I-squared over 90%? All the variations in patients and protocols across the studies created a lot of statistical noise. That noise makes it harder to prove definitively that time alone is the sole driver, especially when you average across such different studies. But the researchers didn't just stop at saying trend not significant. They used the equation derived from that meta-regression to answer the most practical clinical question. What's the minimum delay we need to wait to get the predicted risk below that crucial 6% guideline threshold?
Ah, so they worked backwards from the acceptable risk level. That's clever. What was the magic number? How many days did the calculation suggest we need to wait to keep the stroke death risk under 6%?
The calculated delay came out as 4.6 days.
4.6 days. Okay, that's a concrete number derived from the pooled data. Clinically, that translates pretty directly to recommending a delay of at least 5 full days, right?
Exactly. Wait until day 5 or later. And the sources provided a really powerful contrast to hammer this point home. They used the same meta-regression equation to predict what the risk would likely be if a surgeon decided to ignore this and operate much earlier. The predicted risk for stroke or death if CEA was performed after only 2 days delay was significantly higher, estimated at 7.8%.
7.8%. That's substantially above the acceptable 6% threshold. That prediction alone should really give pause to anyone thinking about operating on day 2 or 3 after IVT. It provides pretty solid evidence that going in too early, primarily because of that bleeding risk we discussed, pushes the patient into unacceptably dangerous territory.
Yes, and it's worth noting that the prediction interval, sort of the margin of error, around that 7.8% figure was also quite wide, which means 7.8% might even be an underestimate of the risk for some patients operated on that early. The data strongly advises against it.
Did any of the individual studies included in the meta-analysis provide findings that seem to back up this 5-day or maybe 6-day waiting period?
Yes, absolutely. The overall finding aligns well with at least one specific study they mentioned, by Villimana and colleagues. That particular study reported observing a progressive decrease in both stroke risk and, importantly, ICH risk in their patients as the time from IVT increased. And they specifically noted that the risk profile only seemed to become comparable to patients who hadn't received IVT around day 6. So having a specific study find that day 6 benchmark really reinforces the calculated 4.6-day minimum from the meta-analysis and solidifies this recommendation. You really need to wait until at least day 5, possibly even day 6, to let things cool down.
Okay, the evidence seems pretty clear then. To safely perform the needed CEA surgery after a patient has received IVT, the surgeon really needs to hold off for at least 5 full days. This allows time for those systemic effects of the IVT, particularly the damage to the blood-brain barrier and the general tendency towards bleeding, to subside enough to bring the surgical risk back into an acceptable range. So we've landed on what seems like a clear, evidence-based protocol. Wait at least 5 days, simple enough, right? But now we have to face the really difficult part, the messy reality of that clinical tightrope. You tell the surgeon, wait 5 days. But for those 5 days, the patient is sitting there with the very same unstable, badly blocked artery that caused the stroke in the first place. That artery hasn't gone away.
This is absolutely the core clinical conflict. And it puts tremendous pressure on the treating clinicians, the neurologist and the vascular surgeon working together. They are forced to weigh two very bad potential outcomes against each other. On one hand, the complication risks of doing the IVT-CEA surgery within those first 5 days, which the meta-regression predicted, could be around 7.8% for stroke death. And on the other hand, the ongoing untreated risk that the patient might suffer another stroke or have their current symptoms worsen during that mandatory 5-day waiting period because the underlying problem hasn't been fixed yet.
And we actually have some data that tries to quantify that risk of waiting, don't we? Which is maybe the hardest number for a clinician and the patient to stomach.
We do.
Yeah.
The sources specifically reference a multi-center registry study published by EA and colleagues. This registry focused on 128 patients who had IVT and were waiting for CEA. And what they reported was really sobering: a 5.5% incidence of recurrent stroke, or a definite progression of their neurological symptoms happening while they were waiting for their scheduled CEA. And that particular study group, the median waiting time was 4 days.
Okay, let's just pause on that. 5.5%. So you follow the guideline, you wait the 5 days to get the surgical risk down from a predicted 7.8% towards that 6% goal. But during those 4 or 5 days of waiting, you're subjecting the patient to roughly a 1 in 18 chance of having a completely new, potentially devastating stroke because the carotid artery is still unstable.
It perfectly illustrates the incredibly difficult position clinicians are in. There often isn't a truly safe path forward in this scenario. The clinician is essentially forced to choose their poison. Do they accept the higher risk of a postoperative hemorrhagic disaster, a complication potentially directly caused by their intervention? Or do they accept the arguably similar risk of an untreated recurrent ischemic stroke, a complication that happens while they're observing? It's a terrible trade-off.
This complexity must mean that while wait 5 days is the general rule, there have to be exceptions, right? The guidelines can't be completely rigid. If the patient seems perfectly stable neurologically, waiting 5 days is the clear evidence-based choice. But what if the patient starts showing subtle signs of worsening on day 2? Or has another TIA on day 3? Does the surgeon have to just watch?
That's where clinical judgment becomes paramount, and it requires really careful, individualized risk assessment that goes beyond just the average numbers from the meta-analysis. The decision has to factor in things like, how big was the initial stroke on imaging? Is it tiny or massive? How tight is the carotid stenosis? Is it 99% blocked? Is the patient's blood pressure stable or labile? Are their symptoms actively worsening? All these factors modify that risk-benefit calculation for that specific patient.
Okay. Now, as powerful as this meta-analysis is, giving us that 4.6-day number, it wasn't a perfect study. It wasn't a randomized controlled trial, an RCT. We have to be honest about the limitations of the underlying literature, which the researchers themselves pointed out.
Absolutely. And the biggest limitation inherent to this kind of work is that all 11 studies included were retrospective. They were looking backwards at data that was collected mainly for clinical care, not for a specific research question. And whenever you do that, you can never completely eliminate the possibility of selection bias influencing the results.
Can you explain how selection bias might have specifically affected the findings about timing?
Well, it's sort of a classic which came first problem. Think about the patients who did have surgery very early, say on day 2. Why did the surgeon choose to operate so soon on that particular patient? Was it maybe because the patient seemed remarkably stable, had a small stroke, and the surgeon felt confident? Or conversely, was the decision to go early driven precisely because the patient was showing worrying signs, maybe recurrent TIAs, maybe fluctuating symptoms, and the surgeon felt they couldn't wait? If it's the latter, if the sickest, most unstable patients were the ones rushed to surgery early, then the early surgery group would naturally have worse outcomes, partly because they were the sickest patients to begin with, not solely because of the timing itself. This bias could potentially mean that the calculated 7.8% risk for operating at 2 days is actually an overestimate of the risk purely due to timing.
That makes sense. What other important factors, potential confounders, were just too inconsistent across the studies for the researchers to really analyze properly?
There were several key clinical details that you'd ideally want to account for, but the data just wasn't reported consistently enough across all 11 studies. First, as you alluded to, the precise size of the brain infarct, the stroke area. You'd expect someone with a tiny lacunar stroke might tolerate early surgery much better than someone with a huge hemispheric stroke, but they couldn't track that consistently. Similarly, the initial severity of the stroke symptoms, often measured using the NIH stroke scale score, was likely highly variable between the studies and wasn't factored in.
And what about managing the bleeding risk itself, like blood pressure control?
Yes, that's a huge one. The protocols for blood pressure control, both right after IVT and during and after the CEA surgery, were highly inconsistent between studies, or often just not reported at all. We know that keeping blood pressure within a very tight controlled range is absolutely vital for minimizing bleeding risk after IVT and during CEA. If one hospital let blood pressure run high, that could increase bleeding risk. If another kept it too low, that might increase ischemic risk. So inconsistent blood pressure management, rather than just the IVT drug itself, could theoretically be driving some of the differences in hemorrhagic complications seen between studies.
And we can't forget about managing other blood thinners, right? Like aspirin, Plavix, or heparin used during surgery.
Another major unknown, unfortunately. The protocols for managing antiplatelet drugs, like stopping aspirin clopidogrel before surgery or not, the use of anticoagulation, like heparin, during the CEA, and especially the specifics of how or if heparin was reversed afterwards, these were all non-standardized across the studies. How surgeons handle these other blood-thinning medications would significantly impact both the bleeding risk and the risk of clots forming. The inability to adjust for these variations definitely adds some uncertainty to that precise 4.6-day timing recommendation.
Okay, and one last point on scope. This analysis focused purely on IVT, the chemical clot buster. Did it tell us anything about the safety of doing CEA after the newer endovascular thrombectomy procedures where they physically remove the clot?
No, it didn't address that. The researchers were very clear that they focused exclusively on systemic IVT because it's still the most common initial treatment, and it's the one directly responsible for the systemic increase in bleeding risk they were investigating. The outcomes after CEA following modern thrombectomy, where maybe less or no IVT is given, is a different scenario. That likely has a different risk profile, especially regarding bleeding, and it remains a really important area for future studies.
Okay, so despite all those limitations, the retrospective data, the confounders, the sources did manage to pull together some practical, actionable recommendations for how we might improve care moving forward. What do they suggest for a safer perioperative protocol?
The main thrust of the recommendations is to adopt a really strict protocol specifically focused on minimizing that number one threat, the intracerebral hemorrhage risk. And probably the most practical, concrete step they recommended is to get repeated brain imaging, either a CT scan or an MRI scan, before taking the patient for CEA, even if they seem clinically stable and you've waited the 5 days.
So do another scan right before surgery. Why? To catch those delayed bleeds.
Exactly. It allows the surgical team to actively screen for patients who might have developed some hemorrhagic transformation of their initial stroke in the intervening days, even if they don't have new symptoms. If that pre-op scan shows the stroke area has started to bleed, even a little bit, the decision to delay surgery further or perhaps reconsider surgery altogether becomes much clearer. It helps filter out the highest risk patients who shouldn't proceed right then.
Makes sense. What else did they call for?
Well, beyond the pre-op imaging, the authors really emphasize the need for future prospective studies designed from the start, to answer these questions, to clarify the optimal way to actually manage the surgery itself in these patients. Specifically, they called for research into the best operative techniques, like should we be using shunts more often or less often during clamping in these IVT patients, and critically, establishing clear consensus guidelines for blood pressure targets and for managing antiplatelet and anticoagulant drugs specifically tailored to this high-risk IVT-CEA population. We need protocols that really bridge the gap between the neurological concerns about bleeding and the vascular surgeon's need to operate safely.
This has been a really fascinating and incredibly detailed exploration of what is truly a major clinical challenge. Let's try and synthesize the absolute core takeaways for everyone listening.
Okay, I think the first key point is actually somewhat reassuring. Performing CEA after a patient has received IVT for stroke is feasible. And on average, if you look at the 30-day outcomes, the combined risk of stroke or death, around 5.9%, does fall just within that generally accepted 6% guideline threshold. And importantly, That initial fear that the IDT itself massively increases the risk of having another ischemic stroke during the surgery seems to be lessened, as long as you're comparing apples-to-apples stroke patients to stroke patients.
Okay, so it can be done safely overall. However, the absolute critical factor, the overwhelming determinant of safety, is timing. The data seems definitive. Operating too early, specifically under 5 days, pushes the risk way too high. And that early risk is driven almost entirely by that frightening 25-fold increase in brain bleeds, the ICH risk, plus the higher risk of neck bleeding.
Absolutely. Therefore, the practical, evidence-based recommendation that comes out of this analysis is clear. CEA should generally be deferred for at least 5 full days after the patient received intravenous thrombolysis. That delay appears necessary to allow the patient's body, particularly the blood-brain barrier and the overall clotting system, to recover sufficiently from the effects of the IVT drug.
A clear rule: wait 5 days. But as we discussed, that rule immediately runs into the terrible dilemma of the risk of waiting. And that brings us perfectly to our final provocative thought for you, the listener, the challenge that every stroke team faces with these patients.
We've established that delaying surgery past 5 days seems medically necessary based on the data, primarily to manage that hemorrhage risk. But we also heard about the EJ's registry data showing a worrying 5.5% incidence of recurrent stroke or worsening symptoms happening within that mandatory 5-day waiting period. So the question for the clinician at the bedside is, how do you ethically or clinically manage the patient who starts to deteriorate neurologically on day 3?
Does that 5.5% risk of having another stroke while you're waiting justify breaking the 5-day rule and operating early? If a patient is clearly worsening and the surgeon decides to intervene on day 3, they are knowingly accepting that higher predicted 7.8% surgical risk of stroke and death, driven largely by bleeding. What specific clinical signs or imaging findings, things that go beyond the average statistics, would convince you or should convince a clinician that it's actually safer to take the immediate surgical risk rather than wait and risk an inevitable recurrent stroke? How do you make that impossible trade-off?
It really highlights that clinical wisdom in these complex situations isn't about finding a pathway with zero risk, because one doesn't exist here. It's about having the best available data to understand the boundaries, and then using deep clinical judgment to choose the least bad option for that individual patient right at that moment in time.
A truly complex and compelling challenge indeed. Thank you so much for walking us through all the nuances of this critical deep dive.
My pleasure. Thank you.